Hello and welcome to Pain Management 105. This is the fifth lecture in a series of lectures on pain management, and we will be talking about different therapeutic interventions used to treat pain. So let's talk about proper drug selection. So when we talk about pain management, with which classes of drugs are we going to be talking about? So we're going to focus on non-steroidal anti-inflammatory drugs, local anesthetics, opioids, NMDA receptor antagonists, muscle relaxants, anticonvulsants, and antidepressants. So here we have a slide on NSAIDs, and this is actually a direct citation from clinical guidelines for treatment of osteoarthritis, I believe. So you can see that non-steroidal anti-inflammatory drugs, both orally but most importantly topically, are recommended by the clinical guidelines as a pharmacological treatment of this disease state. So let's talk about NSAIDs, their mechanism of action, and just a brief overview of their side effects. We will be talking about that in more detail later. So NSAIDs, or non-steroidal anti-inflammatory drugs. So these are going to be some of the most commonly used, some of the most recognized and well-established drugs in the realm of pain management. Why? Because they're highly effective and they work really well. They treat inflammation and they also produce analgesia. They treat pain. The way that they work mechanistically is by inhibiting these two enzymes we have in our body. The first enzyme is called COX-1 and the second enzyme is called COX-2. These specific enzymes are basically involved in the production of inflammatory cytokines. More specifically, COX-1 is an enzyme that's involved in the production of prostaglandins that serve protective functions within our body, for example, gastric protection. And COX-2 is the enzyme that's involved in the production of prostaglandin that signal pain and inflammation. So COX-2 is the bad enzyme. So basically, by blocking production of these prostaglandins that are going to be involved in peripheral and central sensitization, what we're actually doing is remember the transmission of pain signal. Remember the 4 stages: transduction, transmission. So remember how in the transduction, which is the first step in a transmission of pain signal along the pathway to the brain. In the transduction, so first you have a nauseous stimuli, and the stimuli is being converted into an electrical signal. So what we're doing here is we're preventing the production of inflammatory cytokines or prostaglandin that are going to act on the nerve endings and allow them to produce or originate this electrical potential. So we're basically blocking the origination of pain signal in the very earliest stages. So again, some of the key points. So NSAIDs are going to decrease inflammation and pain, bottom line. And the advantage to using non-steroidal anti-inflammatory drugs is that unlike other drugs used for analgesia, for example, opiates, these do not produce central nervous system side effects. Why is that important? Because look at our patient population. If we have elderly patients that are suffering from arthritis, maybe they're not mentally fully there, maybe they're having memory problems. So to have alteration in the central nervous system or central nervous system side effects that are going to further impede their cognitive abilities is bad, right? So using NSAIDs is great in that regard because you don't have those CNS side effects. The disadvantage is that these drugs have an increased risk of bleeding. That's why if patients taking a non-steroidal anti-inflammatory drugs and are going for elective surgeries, the pharmacists and the doctor will actually tell the patient to stop using non-steroidal anti-inflammatory drugs a certain number of days before the surgery. And they also have a potential to produce cardiotoxicity. For safety purposes, BCCA is going to define 1 milligram of topical formulation as 1 milligram absorbed systemically. And we know that's not true. We know that the bioavailability of topical non-steroidal anti-inflammatory drugs is nowhere near the bioavailability of oral drugs, right? We've seen studies where ketoprofen bioavailability is estimated to be about 20% topically, but at the same time, for legal purposes, if you have a pregnant patient and the patient was prescribed a topical NSAID, how do we estimate what's the exact quantity, what's the exact percentage of that NSAID is going to get into her bloodstream? As you probably know, nonsteroidal anti-inflammatory drugs are category B and C when it comes to pregnancy. That means they're not recommended for use in pregnancy. The reason why, depending on a trimester, they're either category C or D is because they cause deformities in the formation of ductus arteriosus, which is a shunt basically in your heart that allows your heart to function properly. So, if you have a drug that can cause potential fetal formation abnormality, it's not safe to give to a pregnant woman. How do we actually estimate how much of that NSAID is going to get in there? We don't know. That's why, for safety purposes, this is what we estimate. So NSAIDs are going to come in oral or topical form, and I'm sure you're familiar with oral formulations. Ibuprofen, Motrin, prescription strength. You have Advil, Aleve, Celebrex. Topical, we're going to talk a little bit more in detail about these drugs later, but you should be familiar with Voltaren, which is just 1% diclofenac, Solarize, which is 3% diclofenac, and also Pennsaid, depending on a formulation, can be 1.5 to now 2% diclofenac. So those three you should also know really well off the top of your head, along with Flector patch. So oral and topical NSAIDs both have established anti-inflammatory effects, and they're very clinically effective. Compared to opioids, they actually lack addictive potentials, but they have a risk of increased gastrointestinal complications. They increase blood pressure, and they also can increase the incidence of myocardial infarction, stroke, and death. Topical NSAIDs are recommended by several different clinical societies, including European League Against Rheumatism, the Osteoarthritis Research Society, National Institute for Healthcare and Clinical Excellence, and also American Academy of Orthopedic Surgeons actually identifies topical NSAIDs, specifically topical, as first-line pharmacological options for those patients who have an increased gastrointestinal risk and have comorbid conditions or have a history of peptic ulcer disease. So what are some of the side effects of NSAIDs? So we have to group them in sort of like three major categories. So gastrointestinal, NSAIDs can cause with chronic use, dyspepsia, erosions, or ulceration and bleed and perforations of the gastrointestinal system. Some of the renal side effects, renal failure can be acute and chronic, also increases in blood pressure and even heart failure with chronic use. And also antiplatelet effects, so basically they can increase your risk of bleeding. So now we're going to talk about local anesthetics. So local anesthetics are the drugs that are going to work by binding to the sodium channel, binding to the hydrophobic pocket within the sodium channels, and basically blocking conduction of electrical signal along the nerves. So again, when we think about our pain transmission pathway, this is also, you're affecting the pain transmission pathway by blocking the conduction of the electrical signal. So when you think about local anesthetics, you have to take into consideration their lipophilicity. Basically, highly lipid-soluble agents the ones that, like the fat, tend to be more potent, and they have a longer duration of action. And then for those of you who are really well versed in chemistry and organic chemistry, stereochemistry basically just refers to the orientation of the molecular structure of the drug, basically the different spatial orientation, and based on the orientation of the molecule of this drug, some of the local anesthetics can be more potent and also have a longer duration of action, meaning they act for longer periods of time in your body. So let's review the mechanism real quick. So local anesthetics, they actually block sodium channel. So they're going to decrease the rate of depolarization, and basically the nerve cells, they fail to achieve threshold electrical potential. So because they never achieve that potential, they can't form or originate that electrical potential or a signal that's going to be propagated to the brain. So basically what you're doing is you're blocking the conduction of electrical signal in its earliest stages. Local anesthetics also cause peripheral vasodilation, which is basically your blood vessels are going to dilate or increase in circumference, and that can cause flushing and also can cause some false reports of allergic reaction in patients. So considerations you don't have to worry so much about. This is more for if you're a pharmacist or if you're a medical professionals, but just know that different local anesthetics can be metabolized differently. They also have different measures of potency. And note that in topical preparations, local anesthetics are fairly safe, but when they're used as anesthetics, there's a lot of toxicities that this drug can cause, including respiratory arrest, coma, convulsions, unconsciousness. And this is the reason why, for example, a lidocaine is a class 1B antiarrhythmic, so it can be used in ventricular tachycardia. That's why they have these are dangerous drugs and they have a potential to produce a lot of side effects. So let's look more at lidocaine. So this is a Fujairah ointment, and it's lidocaine 5%. So you can see there are commercially available products that are topical. And what is the proper clinical niche for the use of this drug? So you would consider treating somebody with a topical lidocaine treatment if a patient has a mild pain or when systemic agents are contraindicated. So this would be a very good first-line drug for somebody who is elderly or somebody with polypharmacy. Polypharmacy means that patients are using a lot of different drugs. It doesn't mean that they're going to a lot of different pharmacies. It just means that, let's say you have a patient who is a diabetic and they also have a history of cholesterol that's elevated, and they also have a history of high blood pressure. So they're taking maybe 2 or 3 drugs for each one of those conditions, and they're taking agents for pain. So maybe they're using 10, 12 different medications a day, and you don't want to add another drug to that regimen because they're already taking 12 pills a day, so they can only take so much. And then adverse reactions with local anesthetics, specifically with lidocaine, are limited to local reaction, for example, erythema and itching, and it has minimal systemic absorption. So this concludes this lecture. Thank you so much, and in the next lecture we will talk more about different therapeutic options for treatment of pain.